And I would like to acknowledge that I'm in Menang country, the Noongar country of the Menang people, I should say. And I would like to respectfully acknowledge the elders, past, present, and emerging. Then when we started this webinar series, someone said to me, you have to really wonder if you want to do six webinars on the same topic. It was a bit critical, but I think we've proven that in the end it was worth doing it, because you are all still here, and very much thank you for joining us today, and also for those who are watching the recording later. Today it's about how GP as an industry can move to net zero for reducing our own carbon footprint. And here to talk to us about it today is a whole panel of people, which I'm very excited about. I would like to introduce first to you, I will introduce everybody who's going to be involved today, and then I won't be on the screen until the very end. Firstly, I'd like to introduce Nick Sleeman, who you've seen throughout the series, moderating our chat. She's been very active with DEA, Climate Change and Health Alliance, and so she's had a great network of people who she knows. And Nick was actually the one who said, I feel we need to do something to educate the GPs in the Great Southern. And now we actually have the statewide webinar that's actually been looked at interstate as well, and possibly internationally, who knows. So thank you, Nick, for bringing up the idea and being involved. Then I would like to introduce to you Dr. Karen Price. If you wouldn't mind, Karen, to switch on your camera briefly. Karen Price is the incoming president of RCGP, and she's joined today just to give us her answers for the question and answers at the end about what the College of General Practice might be able to do to contribute to some action around moving towards net zero. And Karen, if you can't get your camera on, we'll see you later on when we do the Q&A. Also involved in the chat are going to be Dr. Richard Yin and Dr. George Crisp, who are both very active in DEA. George is an educator, as well as a mentor, as well as an inspiration for our medical students, as well as his colleagues, as well as the wider world, I think. And the same with Richard, who I look up to a lot in spending a lot of energy and motivation for people who are just getting involved in this domain. So thank you both for being there. They will be in the chat later with the Q&A. Also presenting for you today is Dr. Sue Jackson. She is the GP lead clinical editor for WAFA. So her job is to develop and clinically edit the health pathways. And so she's taken an interest in a webinar series, and she's wanting to, as you're doing a presentation for us as well, on how the health pathways can incorporate sustainability or other ways. So we'll find out a bit more from you. So thank you so much. But to start us off today, and I really can't be more excited, is Dr. Matt Sawyer, who's actually in Winter Wonderland in Yorkshire somewhere, North Yorkshire in the UK. And it's early morning hours. He's been a GP and he's worked around sustainability for at least a decade and a half, if I'm not mistaken. And he's just told us that he can talk for hours and hours. So hopefully we're going to get the finest of his pearls of wisdom on how come the UK has set some targets and we haven't. So thank you so much, Matt, for being with us this morning. For you, it's afternoon for us, but I'm so appreciative that you've given up your valuable sleep, and I'm very excited to hear what you have to say. Thank you.
No, thank you very, very much, and thanks to everybody for having me this morning. It is 4:45 in the AM, and I've always said that I will talk to anybody, anywhere, anytime about sustainability, and this is the proof of that pudding. So I will run through things relatively quickly, because I know that we've got a lot to try and get through in a relatively short space of time. So I'm Matt Sawyer, been a GP for 15 years now. I'm really interested particularly in improving patient outcomes, but from an environmentally sustainable position. I spend a lot of time looking at things like carbon literacy and carbon footprints. Declaration of interest, I do run my own business which provides carbon literacy training to healthcare staff, and I do carry out carbon footprinting of GP practices in the UK. and I've done some additional degrees and masters in this neck of the woods. So, a few questions. Things that we're going to have a look at today. Why we in the UK have got it easier. Healthcare will be on the front line again. What are the hotspots in primary care? What sort of solutions might we have? And what is your plan? Now, this is all UK data. This is a UK perspective, but I hope that a lot of it crosses over for yourselves as well. So, first of all, why do we get it? Why have we got it easier over here? Well, actually, from our point of view, sustainable healthcare is really about the ability to provide health needs without compromising the ability of others, but not limited to just future generations to meet their health needs. We've got a lot of resources nationally. We are celebrating the 12th or coming up 13th year of our Climate Change Act, which was amended last year. So we have now got legally binding net zero targets for 2050. So we've got a variety of criticisms of our government, but this is one which I think we are leading the world in. If you've not already seen it, in October we launched, the NHS launched a net zero health service, and there's a very useful document available. We know that we've got international journals like the Lancet and the BMJ who have got a lot of really good resources. And importantly, there's the UK Health Alliance. And this is something which I would suggest that is something which might be replicated elsewhere. This is really showing that tackling climate change is a team event, and each of the colleges of medicine, along with a whole host of other key players, so nursing, etc., are absolutely essential to be able to tackle this as a group. And no one person or one organisation will be able to do it on their own. Our UK Royal College has declared a climate emergency, which again I think shows the direction of travel for GPs. We've got individual hospitals, so the hospital not that far up the road from me, Newcastle, declared a climate emergency first in the UK. But we've also got a lot of GPs who are really keen, really interested. Green Impact for Health is a scheme which has basically got bronze, silver and gold and carbon awards, well worth having a look at. And from a financial point of view, this is really important. The bronze award saves practices on average £1,000 a year. So this is not saying that sustainability is going to cost money. There is some investment up front, but actually you reap that reward and reap the financial benefits with the bronze award. Through changing your actions, and practices report £10,000 a year savings once they get to the gold award. We've also got various other websites which are well worth having a look at. The Greener Practice is down in Sheffield and has got a lot of really good resources in one place, including things like online presentations. Greener Inhaler does a lot with taking the guidance that we have from NICE about greener respiratory pathways, and the Centre for Sustainable Healthcare is again really useful resource. So we've got it easy because we've got some national support, but we've also got GPs on the front line who are saying this is really important to us. Just to say, I know that you've already covered this, so I'm going to touch on this really only very briefly. We know that there are a huge amount of impacts of climate change, and we know that these will vary from country to country. In the UK, we have excess A&E attendances, death rates, crime levels, more flooding, all sorts of things that will affect physical and mental health problems. And just as we've been in COVID, we will be on the front line again. Our patients will come to us. So just thinking about general practice, do we know where our hotspots are? Do we know what impacts we're having on the planet through our actions? So I will come back to this at the end, but these are 5 things that we see in everyday practice, and it's, do you know where the which order these would be listed in terms of largest carbon footprint to smallest carbon footprint? Some of them you might be a bit more familiar with. So this is not really about saying whether we should or shouldn't do these things, but it's just saying that this is what the footprint is at the moment. And we'll come back to the answers at the end. Now, one of the things that I do is carbon footprint individual practices. So this is a small 3,000 patient urban practice, and prescribing is actually the biggest chunk of where the carbon emissions come from. So from my point of view, that's an absolutely key area to think about the impact of what we do when we're at work. In the UK, we do quite a lot on social prescribing, green prescribing, blue prescribing. So blue prescribing to us is anything that involves water. So surfing, for example, would be blue prescribing. And in terms of the physical and mental health benefits of that, we don't get quite as much opportunity in the northeast of England, especially at this time of year. And all of the thinking about all of these other types of prescribing rather than pure medication prescribing has an overall impact on what the footprint of the practice will be. But then there is a proportion of the practice that is under your direct control or under our direct control. And the hotspots really depend on the size of practice, both in terms of numbers, but size of practice in terms of floor space. Again, these are UK figures. So for this practice, energy was about 50% of the operational carbon, the everyday stuff. Then there are about a quarter is professional services, and I'll come back to what that means in a moment. We've got a lot of travel and the impact of travel costs, and then we've got the rest, everything else, and this is procurement of office equipment or medical equipment, blood pressure machines, that sort of thing, and waste disposal and recycling. And looking at the amount of carbon associated with waste, in the UK for a practice, it's less than 0.5%. So one of the things that I say every single time is that we cannot recycle our way out of the climate crisis. It is just not going to happen. If that's what we focus on, and I don't know about Australia, but we have a lot of companies saying, but if you don't use a plastic straw, we're going to be fine, forgetting that actually that's a 0.0001% of their overall footprint. Different practices have got different size footprints. The small is about 3,000 patients, medium about 6, and large about 9,000. One of the reasons that the medium-sized practices that were looked at are have got a smaller overall footprint is that they actually had a smaller floor space, and energy in particular is driven by amount of floor space. The other was that some of the medium practices had things like Tesla power walls and solar panels, and so ended up with less energy being used. And this is really trying to show that there isn't a one-size-fits-all approach. This is very much down to each individual practice will have its own individual challenges, and if you don't look to see what your challenges are, you'll never find out, and you can end up looking at completely the wrong thing. So, for example, if actually your energy generation is pretty close to zero because you are self-sufficient, well, actually trying to target that is the wrong area. So I'm going to briefly have a look at some of these areas. So for me, whole life carbon or operational carbon should also include the running carbon, and that includes the travel to and from the practices for both staff and customers or patients. So placing buildings a long distance from a workforce or from its customer or patient base just doesn't make any sense. So these are small, medium and large practices in Manchester, and for a small practice there was still 50,000 kilometres per year of cumulative travel by vehicles. And for a large practice this was 170,000 kilometres, and this ranges from about 10 tonnes of carbon dioxide emitted to about 30 tonnes of carbon dioxide. And this is just looking at carbon at the moment. But one of the questions is, well, why is this important? Are there any other impacts of travel? And this is a book called There's No Planet B by Mike Berners-Lee, a really interesting guy. His brother is Tim Berners-Lee, who certainly in the UK is known as the godfather of the internet, or maybe just the father. Anyway, his brother, Mike Berners-Lee, runs and does a lot on sustainability. And this is a diagram saying the amount of life lost for 1 mile travelled in these vehicles in these conditions. So if you are driving a diesel car across a town or a city, for 1 mile travelled is 12 minutes of life being lost from the surrounding community because of air pollution, particulate matter, etc. So that 5 mile trip to the GP or to the supermarket or the school drop-off is 1 hour of life being lost for one vehicle travelling once. So actually, you can start to multiply this up and think, well, if I fill up a tank, I don't know how big diesel tanks are in Australia, but a 360-mile tank of diesel is 3 days of life being lost for one vehicle. And when you start then thinking, well, if we multiply this and think about, the cumulative damage that a practice is having, well, 50,000 kilometres for a small practice is about 30,000 miles. And if they were in a petrol car, that's 75 days of life lost. In a diesel, it's 250 days of life being lost. So this is, appreciate, unpopular, and I suspect that the way that the government is in the UK versus in Australia, and the distances having to be travelled. But what I can do as an individual GP is not buy diesel, not buy a diesel car, change my vehicle. Again, this is, the distances that we have to travel are obviously far less. But equally, we know that 83% of journeys that are under 1 mile long can be walked. So actually, if we start placing facilities within a mile or within a 20-minute walk of people, actually they are then much more likely to walk, and we can then incentivize positive behaviour. We can incentivize workplaces and employees. At our practice, for example, there are 3 GPs, we've all got electric cars of one sort or another, and we've got an electric car charging point. So actually we can charge whilst we're seeing patients. Professional services is another big area, and this is the telephone services, the accountancy, the financial services, payroll, banking, insurance, all sorts of other things. And really it's saying that what your carbon footprint is to your suppliers actually affects your carbon footprint as a service provider. So every time we spend money, we buy a vote for the type of businesses that we want to support. So one of the questions that we ask of people that we want to spend money on is, well, what's your environmental policy? What are you doing about environmental issues or about climate change? And if they say we don't have, we're not interested, well, that's fine. We just won't spend our money there. And I think that the same is true sort of, outside of the workplace as well. So for me, if you buy a service from a high polluter, then you are partially responsible for the pollution and the proportion of their emissions. So for me, this is about using our influence and our purchasing power and our procurement practices to influence and to lead by example. But then we need to highlight what we're doing and to be able to say the reason that we're doing it is because actually we are interested in the longer term health of our patients. So professional services, I think, is one of these areas which we often forget about, but is actually really, really important. Energy, I'm not going to delve into this because I suspect that there's quite a few differences between UK and Australia anyway. I suspect there's quite a lot of local resources that practices are able to access. This is a picture of the energy hierarchy, which is what we tend to use. So it starts with, actually, is there a way that we don't have to use the energy in the first place? So, for example, we have light sensors in the room. So if it's bright enough, it's not at this time of year, but if it's bright enough, actually the light doesn't come on, and so that you can't have it on if you don't need it. We have things that will turn the lights off automatically, motion sensors. We go to practices and where they've got sort of these downward lights with sort of half a dozen fluorescent tubes in. We take out a third of them. Actually, it doesn't seem to affect any of the light. People can still see where they're going, and we've suddenly cut a third of our energy use from lighting without actually having to do anything. And then there's energy efficiency. So what you do have is more efficient, and so on down the list. But that for Australia, I suspect, is you're going to be able to find your own resources for that. And then this is the rest. This is the medical supplies, the rubber gloves, the couch roll, the speculums, the uniforms, and then the office supplies, the paper and printing and postage and pens and printer cartridges, and the food and drink. And then it's also the not just the consumables, but the equipment, the desks, the chairs, the pulse oximeters, and all of those sorts of things. And whilst this is a smaller piece of the overall jigsaw, actually this is still really important. But again, I think you can see that recycling is not going to save us, because it's only going to be a very small proportion. And there really is a balance between single-use equipment, waste generation, and sort of the sterilising of equipment. Practice down in Sheffield in the UK has just recommissioned autoclaving of equipment, things like speculum, using the local hospital. So the local hospital has got its own sterile supplies department, and so actually the kit and equipment go into the hospital, get sterilised, and come back, and that is more cost effective, lower carbon, because the journeys are taking place anyway, than buying disposable. Elsewhere in the world, for example, so we'll come back to seeing what the carbon footprint of a cataract operation is in the UK, but there's a system in India called the Arvind cataract system, which reuses equipment and has got a better outcome for patients in terms of infection control with lower infection rates, but also has a fantastically lower waste generation and lower carbon footprint, about 5% of the footprint of a UK operation. So there are examples from around the world of how we can do these things. Certainly in the UK, I get a bit frustrated with a lot of the single-use medical equipment. It is a small proportion, but I get frustrated really because I think that it was brought in the UK about 20 years ago after the BSE crisis. And so for neurosurgery, they said, right, we need to use single-use so we don't pass on the prions. Great idea, but now we do it for skin tags and everything else, and you just think that it's probably gone a little bit too far. So that is a run through. I haven't quite finished because we need to think about what is our plan. So what can we do? So for me, the first thing is knowing where our hotspots are, knowing where we need to do the analysis of a practice. We need to say, actually, we are generating most emissions, most carbon, most waste from this area, these areas. And until we know that, we're really going to struggle. This is an example from the UK, from a colleague up in Newcastle, who has had a look at, well, are there other ways that we can improve patient outcomes, but doing it in a more environmentally sustainable, in a lower carbon way? So this is taking that average 53-year-old with type 2 diabetes who really doesn't want to take any more medication, thank you very much. And it's trying to use our influence to inspire them in different areas. So this is looking at things like active commuting, and the benefits of increased activity for them as an individual is lower diseases of one sort or another. So, you know, cardiovascular mortality or various cancer risks. But it's also them doing more physical activity has got this additional benefit on their family, on their children, who say, actually, I can see that exercise is the right thing to do, and actually the rest of the family then benefit. We've then also got things that we saw previously, that carbonised transport increases the air pollution for the local community. So actually getting this guy out of the car improves the air quality for the rest of society around him. And that then leads to lower illnesses. We know in the UK, for example, or the research suggests that a third of asthma diagnoses are because of air pollution. So in the UK, that's about 50,000 people per year, every year, that we are giving an illness to because of our air quality. So actually getting guys, getting people out of the car in the first place can really make a big difference to that in terms of asthma incidents for patients and children and the rest of the community. But then we've also got this global benefit of the reduced carbon dioxide generation in terms of, you know, the reduction in climate change. We've got a reduced need for medication, so we get less plastic waste, we get less need for inhalers, so there's then less plastics in the overall food chain. So actually, if we can use our influence and saying, look at all of these additional benefits, we can really make some big inroads. So just coming back to, this is the list of those 5 things about what the carbon footprint is per activity. So omeprazole, about half a kilo, but that's for a 1-month supply, and then you can multiply that up by 31.5 million prescriptions, and you think, oh, blimey, that's quite a lot. Flu vaccines, 1.7 kilos per vaccine, and in the UK we give about 7.25 million per year. This is not about saying stop giving flu vaccines. That is not the the suggestion here. It's just saying that we need to be aware of where things are at the moment. In the UK, we've got a lot of focus on incentivising GP practices to reduce the MDI inhalers at the moment and move people over to breath activated. There's quite a lot of work going on that, and certainly if people want more information, I'm happy to help out. GP appointments are about 66 kilos per appointment. Now this is pre-COVID, so this is including all of that travel and all of the other things that that I've talked about. Certainly the telemedicine that I suspect you've been using as well will have a direct impact on that. I suspect it'll be a number of years before we can start to see the clinical impact, what has actually happened to our patients through telemedicine. This has been a very interesting 9-month experiment so far of, does telemedicine lead to good clinical outcomes? It leads to lower carbon outcomes, but what about the health of the population? And this is a UK cataract operation, 180 kilos for an operation, and as I say, the Indian system is about 10 kilos, give or take. So phenomenally better, and with better patient outcomes, and with less waste. You just think, why it's crackers that we keep doing things the way that we do. So for me, what can we do? I think that we can do a huge amount. I think that we can become more carbon literate. We can know where our hotspots are. We can then make pledges. So I've made a pledge to reduce my personal carbon footprint. I'm aiming for a third of the UK average, so I'm aiming for about 5 tonnes per person per year, and I can talk about what that means in your terms as well, if that is needed. We can pledge to reduce our operational work footprint. That's the heating and the lighting and the equipment that we buy and that sort of thing. And then we can pledge to reduce the impact of what we do at work in terms of our patients, in terms of prescribing, in terms of how we can then lead our patients into hopefully a better future. And I think that there's a very important phrase called eco-ethical health leadership. And this, for me, is about using our influence and leading by example. We need to have that inspirational leaderships that really involve the values and the collaboration and the justice and the advocacy to ensure the ecological sustainability, and really putting planetary health as essential for human health. We've got trusted voices in our societies, and we've been anchor organisations for many decades. I think that we need to be able to highlight the importance of this, what we're doing and why, and also show off and publicise our successes. This is how we, I think, bring about real change. Final slide. This is just about saying where we have been in terms of carbon emissions and where we are now. So between 1850 and 2000, we emitted 1,000 gigatons of carbon dioxide across the world. Between 2000 and 2015, we emitted 50% of that, another 500 gigatons. And we're emitting about 36 gigatons per year. So for the world to give ourselves an 80% chance of keeping below 2-degree average temperature rise, and of course we know that the temperature rise and the impact is inequitable, we could safely release another 335 gigatons. Now that was from 2015. Unfortunately, in the last 5 years, we have emitted about half of that. So I think that we're really up against it. We've got 5 years to make some really dramatic changes globally. There was a report out yesterday that said that the change of practice through COVID hasn't led to the significant reduction in carbon emissions that we needed. Unfortunately, on the right side of this, it says that we've got another 2,750 or so gigatons of carbon that is still locked up in the earth. We need it to stay there. If we want, as medical professionals, to look after the health of our populations, we cannot continue to emit and to burn fossil fuels, which I appreciate may be difficult for Australian countries around the world. But that's it. And so that's me. So I'm more than happy to take questions, and I'm here for as long as is needed. Thank you very much.
group of education with very little knowledge on this, and I have found it absolutely fascinating, and I've learned a huge amount. And I think for my role now, it's how can this be used more effectively within some of the things that we have, such as health pathways. So who are we? We're an online portal designed by GPs, for GPs, but also we're used by all health professionals. So anyone with a practicing certificate can access our pathways. We launched in 2015 with 115 pathways. We now have over 600. We aim to provide concise information. Oops, let me go back. Concise information on what services are available across the whole of WA, but there are equally similar organised health pathways regions over the whole of Australia and New Zealand, and now several in the UK. So there's been a lot of recent discussion on disaster planning and primary care, including bushfires over Australia, the earthquakes in Christchurch, floods and cyclones, the pandemic particularly. And this has made us think a lot more on how prepared we are for this. And in all honesty, we haven't been particularly prepared. And I think the other disturbing thing is there's been a lack of involvement previously with primary care engagement in these things. And that's now starting to be addressed, but we're a long way from getting full engagement. We learned a lot of lessons in managing COVID. A lot of these will be used moving forward. One of the things that we did do over Australia during COVID is all the clinical editors over the different regions, and there's about 40 of them, who were involved in COVID, writing COVID pathways both in Australia and New Zealand, got together on a regular basis, and we shared the workload, which means we could be more effective. It helped us all keep up to date on new information and be able to make changes as they occurred, which were very rapidly during this time. But this is something we have agreed as a group that we want to take forward and use it in different areas. And listening to all this information on climate change, I think this would be an ideal topic to actually work on across the whole of Australia, not just in Western Australia. There is already one area, Western Victoria, who have started producing some pathways, which I'm watching with interest and have been in contact with them about it. So I think this collaboration and the information sharing would work very well with climate change and climate change medicine and greening practices. And I think this topic is very applicable to actually having some national pathways. And we're just in a situation where we're actually starting to develop pathway sharing on a much greater level than has already occurred. And part of this will be the development of some pathways that sit nationally. So I'm hoping that climate change medicine can be one of these. So looking, I'd spent some time and I had a look what pathways were already available across the regions. And this is the list that covers mainly post-natural disaster health, mental health, trauma, GP management in an emergency, because one of the things we learnt during COVID that we hadn't done previously is actually produce pathways on how to set up general practice. What measures needed to be put in place in general practice to actually manage COVID. And again, I would see this as very translatable to how general practices can manage their carbon footprint. Preparing general practice for disasters and external emergency and mass casualty plans. So there's a lot of stuff there already. They're maybe not as specific as we would like on the actual medicine side. But as I said, Western Victoria have already published some pathways on asthma, thunderstorm asthma, and they have another one underway on smoke inhalation, which should be out in the next few weeks. Currently, there are no specific climate change pathways, and one of the first steps that we've been looking at is gauging interest across the regions, which I'm in the process of, and there seems to be quite a lot of interest. And I'm sort of hoping that if people coming to this subject like me suddenly see what can be done within general practice, there hopefully would be a lot of uptake. So I've already spent a little bit of time considering how this could be done. Obviously, there's a lot more work to do, but I think one of the early things would be actually having a working group with a lot of the people that have actually been present at these meetings with, you know, where do we start? What are the important things that we need to get across? And how do we translate this to Health Pathways? Because Health Pathways follows a very prescribed format, because it sits across so many different regions. We all follow the same style plan, we all follow the same formatting and language. So we'd have to look at how we could do this. I think one of the big things that would be helpful in making change is inclusion of climate change medicine into some of our existing pathways. That and again, I would need to go to our clinical editors group and have some discussions. And hopefully I'd like to share some of the slides from these meetings to see if we can then start, when we're actually localizing a pathway, looking as part of a routine of where do we put some climate change medicine into this, so GPs can start talking to their patients about it. I think it's important to look at what new pathways would be useful and how we can work with other regions so that the workload is spread across Australia. So my question to all of you is, what additional information do we need to include in our current pathways? And I've got some ideas from listening to a lot of this. And I think there's a lot of things that would be needed to follow up on. So we can look at specifically where are the most important things where are places to start? And also what additional pathways should we be looking at long term? I think in terms of Health Pathways, there will be need for a bit of awareness raising, because this isn't something that has been routinely in them up till now. So there's a little bit of work to do around that. So as I said, a little bit of future planning to do, but I think this series has been a great way to start. I think a few more communications out to GPs and a bit more feedback on where we go. And let's see how that goes. Thank you for listening.
For that, would the other members of the panel actually like to bring themselves on to the screen? So Matt and Karen, could you actually put yourself back onto the screen?
Can you see me?
Yep.
Yep.
So maybe we have a number of questions that have actually come up in the chat or even beforehand. And I'd just like, there's a few of them that we can bunch together. And here's one that is fairly common. It's been mentioned a few times in a number of different ways. And it's probably directed to Matt. So I'll actually direct this to Matt to start off with. How do we find a balance between the practical use of disposables and sterilising equipment?
I think that it depends. When you look at sort of environmental impact, it depends on what you're looking at. So certainly from, say, a single-use plastic point of view, then disposables are a problem. If you're looking at the amount of carbon being used, then actually in the whole practice, it's a much smaller piece of it. So it depends on, as a practice, what you want to focus on. And although I've obviously spoken about carbon footprints today, that some practices say, look, actually for us, more important is single-use plastic. That's really what we want to tackle and get right. That's what's in the public conscious. We can't, justify continuing to produce and dispose of things inappropriately. So I would say that for a practice, you need to target what you are most interested in, whether it be energy, transport, single-use plastics. In the UK, certainly we are making use of facilities at the hospitals to be able to sterilise things. So some practices are saying this is really important to us, and that's the way that we're going to tackle it. I know that there's one practice who's looked at sort of the costs of installing an autoclave machine for reusable equipment. But certainly during lockdown, we just haven't used the same amount of equipment that needs sterilising as we were before. So in terms of time, money, energy, single-use plastics, it's really about getting a balance between all of those. If you're a bigger practice that uses a lot of kit and equipment, absolutely, I think that you may well find that both financially and environmentally it is much, much, much better for you. But it's going to be an individual practice to determine whether that's right for you or not. And sometimes the collaboration with other practices and actually saying, do you know what, actually we're all going to have minor surgery on the same day between 2 or 3 local practices. Let's send all of our equipment off together. To be able to sort of, economies of scale. One of the things I think COVID's done is allow us to have conversations with colleagues in other practices that just weren't there before. So this would be a really good area to work as a cooperative.
So I have another question in the chat here, and this is probably best directed to Karen. Can RACGP support getting data on emissions in general practice, such as those available in the UK?
Absolutely. We'd love to do that. I'd like to ask Matt one time to, if I can get it through the board, to come out and speak at one of our national conferences. I know we had, I tried to get George lined up for one of our conferences before COVID hit, but it's tricky getting the places, time and people all together. In terms of getting the general practice data, Nicole Sleeman in the chat has talked about her practice. I think it's her practice in Northeast Victoria and what they've done in doing a green audit in their practice and how that saved the practice money. And I think that sort of thing, even though it's not about the money, there's an ethical issue. I think it's a way of capturing the imagination of the people who are basically sitting there. Is it Jared Brownstein's practice, Nicole's just said? So it's a way of capturing people's attention where they may not be focused on this particular issue because they're under the pump. So I think there's a whole range of things, and obviously we'd be guided by the National Faculty of Specific Interest and the Doctors in the Environment of Australia. So a lot of goodwill. I think it's just getting it into the national agenda and making sure we've got some actionable items that are achievable to keep each year bringing that up as a way of moving forward, moving the college as an organisation forward. Another idea was getting something like Nicole's, Jessica Kneebone's article there about appointing a green champion in the practice to help drive change. That's something that could be considered as something in the accreditation guidelines and that sort of thing. So I think those sorts of things that we can action and keep bringing it up regularly are important. Yeah, that's where I think we'd like to go.
So I'll just ask George to comment a little bit on what's happened with our practice in terms of some of the sustainability measures and the cost savings there.
Yeah, I mean, it obviously wasn't the prime reason to make these changes. We were looking at reducing our impact,
Yes.
and energy was one of the things that we could sort of measure more easily. So, of course, the cost impacts are quite relevant. We're just spending a lot of money doing it, but it's turned out that it's actually very cost beneficial, far more than we thought. When we put our solar panels on in late 2016, we had some trouble because our roof wasn't very is not very strong. We had to build an extra structure, but which put the cost up a bit. But even with that additional cost, for 3.5 kilowatts of solar panels, which was the maximum we could fit, the payback period actually has turned out to be just about 3 years, which is certainly less than we'd anticipated. And of course, now we're getting free electricity. But the other thing, I tried to calculate out how much carbon it saves. And the closest that we can really work out, it's about 5 tons of carbon dioxide a year from our one practice, which is a 3-room practice, with one nurse's room. So, we could have done better if we'd had a bigger roof and could put more panels on. But even with that, with our limitations, that's pretty impressive. We also put solar hot water in. So before 2017, we were spending about $350 a year on gas for solar water heating. We're now completely solar. We've disconnected our gas. And the payback period on that is actually going to be around 7 years in terms of economics.
So there's another question here about, it's actually quite a number, maybe directed at Matt. It's about how do we have conversations with our patients about sustainability and about climate change?
Thank you. This is, I think, something which is going to be increasingly important. Again, I think that it's got to be made personal. So what I tell you about the UK is going to be different to what you consider in Australia. We haven't had quite the same wildfires, for example, but we get more flooding, or I'm thinking that we have. So for me, the way that I bring it up in conversation is it's very much led by the patient and their illness, their disease, their questions. So if somebody comes in with, say, bowel problems, stomach upsets, it opens the door to talk about sort of, sustainable diets, for example, and saying, look, actually from a planetary diet point of view, this is and we use the Canadian food plate model, and say this is really good for you and it's really good for the planet. So actually I'm doing you as a patient a benefit here, and you are actually doing society a benefit as a result. From an asthma point of view, it opens up the door to be talking about cars and travel and active travel and kids on the school run, and the number of mums that sort of go, oh, I hadn't realised that me getting in a diesel to drive a mile down the road was quite as bad for the surrounding society. So I think that it's very much about raising the questions that are linked to what the patient is asking about. I don't think that any of us benefit from me just prodding you in the chest and saying, but you need to do this, if it's way down your priority list, or actually it's something that you're not interested in. So I think you've got to make it very relevant to the patients, and hopefully there's going to be something in the BMJ around exactly this in a few weeks' time, because it is really important that we use our voices in a very effective manner. So that, to me, is about being up to date ourselves as we are in clinical issues, but just being able to say to the patients, look, this is really good for you and really good for everybody else around you.
I think it's really interesting, the social prescribing that you mentioned, Matt, because we've got the handy guidelines at the RACGP, and I know Paul Glassieu and others are going for another round of reviewing the evidence. And I just wonder whether they have an impact on climate involved in developing those guidelines for social prescribing for patients. You mentioned the surfing and the blue prescription. I think that could be taken up widely.
Yeah, I mean, we think that every Australian goes surfing on a daily basis. I'm sure that's not quite the case.
Not quite.
Maybe, yeah. But I think that, for those who are interested in it, you put the positives. It is about that green space. It is about the mental health. It is about, the cardiovascular health. But it's also leading by example. So, for example, we've got a practice locally to us where the GPs are taking the patients out on a 0 to 5K run. Or a 12-week program, and it is the GP who is running with them. So it's not, I am a GP telling you what to do. It's not that sort of, patriarchal medicine. It's you come and run alongside me, and I will improve your health. And we've seen some phenomenal results in terms of reduced prescriptions for blood pressure medication or loneliness and antidepressants.
Might solve
So,
burnout as well.
yeah, absolutely. Lead by example.
Yeah.
So I just have a question for Sue then. Is there any interest or agency to push the social prescribing agenda within health pathways or within the primary health network in general?
I think there is, but I don't think it's been, excuse me, I think there is, but I don't think it's been fully explored as yet. And I think I actually believe we need a working group to bring some of these ideas out, and then we can start to plan for what can be included in health pathways and what sort of time frame, because there's a huge body of work here, and it probably needs to be tackled on various levels and in various inclusions. So I would probably like to see a sort of long-term plan for how we do start to include this.
So Karen, wouldn't that be a nice collaboration, between health pathways and RACGP about forwarding some of these climate agenda, both in the context of preparing for climate change impacts, but also for, that we do our part, understanding that we're about 7% of Australia's emissions in the health sector.
Absolutely. Yeah, absolutely. I think it's important to start including that, Sue. So happy to chat.
It sounds a good conversation to have. We already have quite a few pathways on lifestyle, and I think that would be a lovely place to start expanding that a bit. We have lifestyle, nutrition. We could add more into these.
Well, yeah, I think in collaboration with the handy guidelines and, which is describing the evidence, but then moving it into an actionable thing with a framework that discusses climate and climate health. Fantastic.
So I have another one here. I'm interested in how I can reduce emissions with my prescribing habits. Are there any particular medications that carry a bigger footprint than others? Could you talk us through inhalers and the various footprints, but also other medications, please? I think that's Matt.
Absolutely. Yeah. Inhalers, it's the propellant in metered dose and breath activated inhalers that are the real killer from a climate point of view. So certainly in the UK, we've got nice guidance which talks you through the right inhalers for the right patients, because that's absolutely critical. It talks you through inhaler technique. There's a huge amount of work looking at the right pathways for people, and I suspect that some of those are directly comparable with or transferable to Australia. So the way that I approach it is, what can the patient manage? So, do they have hand-eye coordination? Can they use one piece of equipment over another? I think in the UK, we've always used Evahalers, meter dose inhalers. We're very SABA heavy, we're very salbutamol heavy in terms of our prescribing, and it's trying to move people away from that. To me, it's looking at the whole pathway and saying, how can we make better respiratory care for patients, less disease burden in a more environmentally sustainable way? It's not just about giving people a low carbon inhaler. You've got to have the education and the inhaler technique to go along with that. I think if we can do a whole session on this. I've done a number of presentations to the Royal Society, Primary Care Respiratory Society on exactly this, and it may be that that's a place for a bigger discussion. Upshot really is, if you improve patient outcomes with dry powder inhalers, get their technique right. So 90% of people who use meter dose inhalers do it wrongly. About 70% of people who use dry powder inhalers do it wrongly. The technique is absolutely vital, but people generally manage the dry powder better than the metered dose. But it's so if you can improve patient care, actually you end up with a lower carbon footprint. There's a website called Greener Inhalers, which .org.uk, I think, which is well worth looking at. It lists all of the inhalers, the carbon footprint per inhaler, and so that if the carbon is the only thing that you're interested in, that's probably the best place to go. Somebody's put about nebulizers. Certainly, I think the UK wouldn't advocate nebulizers, and certainly for outside of hospital, we don't tend to use nebulizers, and there's increasing evidence that nebulizers are probably just as bad as the metered dose ones in other ways. But that's a whole topic for discussion and debate. But nice guidance on asthma. There's a really nice sort of 9-page summary, and Greener Inhaler is probably where .org.uk is where I would start.
So we just had confirmation today that the Thoracic Society of Australia and New Zealand actually are forwarding this agenda in terms of a working party to look into this, and hopefully we'll get a response from them in the next few months. And certainly we're hoping to see some recommendations through some of the guidelines, Australian guidelines around this issue. So it's taking place, things are actually moving in the right direction.
Just one other thing, just on the on other drugs, it's very, very difficult because drug companies don't publish the amount of carbon per drug. So I can't tell you what an ACE inhibitor is. I can't tell you what a metformin is. The only reason I've got a meprazole is from a company who let me have that carbon data per drug, but most places don't do it. So it is really, really hard to then say, well, what's your next hotspot? So we're working on that in other ways, but at the moment, it's difficult to know.
I was just going to add to that. I mean, there's probably an enormous amount of overprescribing, isn't there? Even particularly in older patients, who are taking medications that they don't need to be taken, probably doing them more harm than good. And I suppose it's just another reason to actually look at, what medications are we using that there really is little benefit for clinically, and particularly if that is coming at a big environmental cost as well. There's another incentive to actually redouble our efforts to monitor prescribing in that way.
Yeah, deprescribing is vital.
So there's another question here. How can we effectively talk to colleagues and specialists who prioritise air travel for both education and recreation and seem oblivious to the contradictory message this sends about reducing personal emissions? I might just open it up for anyone that wants to take that one on.
Yeah, it's difficult. So the way that I tend to frame things is through what's of most interest to that person. So if I'm talking to a practice manager, for example, it's the financial impacts that you go with. If it's a clinician, it's what are the patient benefits of changing behaviour, doing this action. So different people, I think, need different messages. It's trying to find the hook for those individuals to be able to say, look, actually, this is a problem for you. So, for example, this is just off the top of my head, air travel takes a lot of time. Actually, that's time away from the family. Would you rather do it on Zoom, or would you, and spend more time putting your kids to bed and reading them a bedtime story, or would you rather sort of, fly and have, 2-3 days somewhere else? It's really, really, really difficult and tricky. And there's some people who are at the front of the curve and who are wanting to make the changes, and then there's the laggards towards the back who will only change when everybody else has changed or when they're forced to change. There are, to me, it's about changing those who are in that position to behave who want to change their behaviour. We know from a smoking point of view, from an alcohol point of view, you can bang your head against a brick wall on that, person who's smoking 20 a day who just doesn't want to listen to the messages or change. Well, actually, I would suggest that our time is better spent on those who do want to change, who can change, who will change, and who will then inspire, the next person and the next person. And sometimes if you hear the message from 10 different places, then you make the change, not if you just hear it from one place. It's not easy, though.
So
sorry, Richard, this is Crystal here.
Yeah.
I'm so sorry to need to interrupt you. We have come to almost the very time of our hour together, which is a shame. I think we have had the most interactive chats that we've had in all the series. There's people who are bubbling with ideas, they're bubbling with inspiration, and they really, I think, if we could harness that energy and channel it in the right direction, then I think, we're all trying to do grassroots up sort of things. But if we could structure from higher up, like they did in the UK, and I mean, your example is just like a shining beacon, that if there is a governance sort of structure that says this is what we're all going to do is going to make it so much easier. And I've been thinking a bit like, this is an Australian metaphor, it's a bit like a rain in the desert. You know, that once it rains in the desert, there'll be flowers, everything starts to grow, and people say, isn't this amazing? Like, I think we're all waiting for the bit of rain as to, you know, from higher up, people say, yes, we're going to take the lead and put some actual, like you're saying, Karen, actionable things into place, because then it's gonna really, really flower. That's what I think. And so we're heading towards a 1 hour mark. And thank you, Matt, for giving up your sleep again and for being with us. That has been such a clear summary of what we need to know to spur us into action. And I'm so grateful that you are here today. And same
Pleasure.
for you, Sue, and same for you, Karen, and Richard and George, and for all of you who dialed in and listened to us. Now, there was some remaining questions. We do have an engagement page. So once you go through the feedback, there is a page where we're going to try to endeavor to get all these remaining questions and answers done. And that brings us to the very end of our series. And it's a great conversation starter that we've had and that we've shared with all of you. And thank you so much for being part of it. And all the very best for the last bit of the difficult year. And let's go into 2021 with a lot of action. That sounds good to me. Thank you all.
Thank you very much.
Thanks, Em. Oh, good.